So welcome, I'm Ken Harkey. I'm one of the new professors down there at the ED, clinical assistant professor is what they call me. So I was asked to give a presentation on emergency ultrasound. So here's just some basic, broad swath overview kind of stuff. So what do we use it for? And these are very overlapping categories, but the idea is you use it for resuscitative purposes. Trying to look for an acute resuscitation, what can I do to help this person? Usually falls for like a rush exam. And during code situations, looking for diagnostic purposes. Does this person have an acute chole? Do they have a DVT? Something I need to intervene on? They come in saying I'm short of breath. How do you work that up using ultrasound as a diagnostic modality? Using it for procedure guidance, which is probably, I'd say 50% or more of what we do using ultrasound in the ED. And then therapeutics and monitoring. You can trend IVCs, the response to fluids and pressors, and go from there. So the ultrasounds that fall within our scope: AAA studies, cardiacs, ultrasound guidance, central access, which is usually the standard of care nowadays, fast exams, pregnancy, shock states. Using it for other procedures: DVT studies, thoracics, looking for effusions and pneumothorax, musculoskeletal studies, which are most often underused, ocular studies, looking for increased intracranial hypertension, and peripheral venous access, which I am actually a fan and advocate of. And then you got your rush study, which is a giant conglomeration of different studies in someone who's hypotensive to kind of work up why are they hypotensive in the ED. So basic ideas of ultrasound. We're using high frequency sound waves that aren't to see what's not visible to the naked eye. And you're actually using, the definition of ultrasound is anything above, I think it's 30 kilohertz, which is where your ear stops being able to hear it. We're using around 15 to 30 megahertz ranges. So you're doing pulses of ultrasound in a specific direction, and it's using the physics of reflection, transmission, and refraction. And thankfully the machine takes care of all that to give me a picture. So it comes down to what are your probes and which ones are good for what. So, does this one have a, you can break them down generally into high frequency and low frequency. High frequency probes in general is your linear probe right here. He's small, flat, and long. He's high frequency, which means you get great pictures at a very small depth. But if you're trying to see more than a couple centimeters, you lose all resolution. So for high frequency, you get lots of resolution at a very short depth. So it's great for vascular structures. It's great for looking at an abscess, putting an IV in, doing IJs, things like that. Not good for looking inside the belly, looking at the heart. But it is pretty good for looking at your thorax too, because you don't need to go very far to see what you need to see. You've got endocavitary probes, usually used for any cavitary you want. You can put it in the back of the throat, look for a retropharyngeal abscess, or a peritonsil abscess. You can do endocavitaries for transvaginal, looking for pregnancy, or if you really want to, you could do transrectal for just fun, I guess. And then you've also got your degrees of phased probes. This right here is the one we have here, and that's kind of a catch-all between the two. It makes a nice medium. They're lower frequency, so they don't have great resolution, but they have great depth. So I can see in the belly. I can look at your organs. I can look for heart a lot better. I can look at your uterus a lot better. But I can't see with the exact same definition that I can with the high frequency probes. The physics behind it, the computer does almost all the work, which helps us out. So it's pulses of ultrasound. And you don't see the pulses, but they're there. It can't be continuous because of the way the physics work. It's calculating your distance is your speed times your time, and it's going to generate pixels based on that. When you're looking at the image, your probe is laying here on the surface. It's going to send that sound wave down. It's going to register all this tissue here, subcutaneous tissue, and bounce back a little bit. And then when it hits this aorta right here, that difference in the mediums between the two tissues will send back some to the probe. That will give you the image right there. Then the sound waves will come through here. That'll give you a little bit more reflection, but not much. And then I'll say, hey, there's nothing there. And then it hits the back wall and bounces it back. And then your computer generates this image to show you that. Because of that, you get artifacts. The computer doesn't know that it's an artifact. It's just showing you what it reads from the reflections. So when it comes straight back, it looks like nice and round, and you can tell it. When it bounces off to the side, you'll get these nice shadows coming down the side of pretty much every hollow organ you hit. You just know to expect them so you know what's normal and what's not. Key is to know your enemy, which is generally air. So that's why every time we lay a probe on someone, you should have a nice conducting gel layer right there to decrease the amount of air between you, your patient, and the probe. Also, air inside the bowels will kill pretty much anything they don't want to see. So as long times it's like, being patient, waiting it out, waiting for the air in the bowels to peristalse through, or gently maneuvering the patient around, trying to reposition them so the bowels fall out of the way. That way you can see what you're interested in seeing. But air in general is your enemy. So your probe, no matter which one you choose, it acts like a credit card thin beam. And what you're doing is you're putting it on a spot, and in general you should move one plane at a time. You either go north, south, east, west, AX, Y, or you can rotate, or you can slide. And we'll play with all this later. The key is most people when they first start, they're doing all three at once. And you can't track what you're doing wrong there. Put a probe on, hold it still, see if you see what you want. If not, pick a direction and go. You can either slide, you can either fan, or you can rotate and try and see where your malfunction is. In general, we approach the patient, we stand on the right side of the bed, because most of us are right-handed. Left hand's operating the machine, right hand's using the probe on the patient. Right side of the patient. The probe has a marker on it. That marker will, in general, be to the patient's right side or towards their head. If you keep that in mind, your images will show up in the right direction. Having images in the wrong direction happens all the time. It just shows me you had the probe held wrong. It doesn't mean you're getting bad images. But you don't want to look at it and be like, that liver's upside down. But you can still tell what you're looking at. It just looks odd to the person who's been seeing a lot of these. The major exception to the orientation scheme as described is when you do a cardiac ultrasound and it's completely backwards. You're aiming to the left hip and right hip, and it's different. So ignore that part for now. In general, aim for the probe being to the right or to their head, and you'll keep it right almost all the time. You should be Indiana Jones. You should know your artifacts. That way you get out of problems. There's ring down artifacts where it looks like something's below what you're looking at. There's all different kinds. This comes along in residency training. They teach you to look for them. That way you know this is normal versus abnormal. This is an actual finding versus an artifact. So you'll learn those as you go along. The basic study is a FAST. So FAST is focus assessment with sonography for trauma. It is made to look for free fluid, and it's pretty sensitive. You can find about 200 mLs in someone who has experience with it. A super experienced provider getting great views can probably find less, 1 to 200 mLs, but in general 200 mLs is our cutoff. It doesn't detect blood. That's very important to mind. It detects free fluid. So it could be urine, it could be ascites, it could be amniotic fluid, it could be physiologic free fluid from a normal female. It just detects fluid. It can't tell you what it is. So I can't tell you if that car wreck patient has a belly full of blood or urine. Now when you put the Foley in, there's pure blood out, and they have a decompressed bladder, and there's a giant bladder rupture when they X-lap them. Yeah, it was probably blood. But I just see fluid. I can't tell you what it is. Views you need for a FAST: right upper quadrant, looking for Morrison's pouch; subxiphoid, look at your pericardial windows; left upper quadrant, looking at your splenorenal; and then pelvic, looking in females for your pouch of Douglas, or in males for your rectovesicular space. So here's the basic looks at them. So here in your right upper quadrant, looking for Morrison's pouch. Your liver's right here, probes at the top, going through sub-Q tissue, hits liver. Liver looks like this. It looks like, I don't know how to describe it, liver, like duck liver when you eat it. It's got all these little bumps and nodules in it. It comes down, it's nicely echogenic. And this right here is the interface between where liver transitions to kidney. And then if you have a positive FAST, you'll see black anechoic fluid coming through here, leaking down in. And that right there is the free fluid layering out. Usually you'll see it slurring right up here, and then as you get more and more fluid, it'll progress down all the way through. A good FAST view in the right upper quadrant and left upper quadrant will catch your diaphragm edge. And that makes you feel good that there's no free fluid layering back here hiding that you missed because all you were looking for was up here. So that is a pretty good picture right there, and that's the positive. Subxiphoid, this is always what you do. You do right upper quadrant, subxiphoid, left upper quadrant, and then pelvic. Same idea. There's your skin, your probe, comes down, hits liver. This is a nice 4-chamber view. I will say I generally don't even get anything this pretty, but what I care about is seeing my pericardium. I care if there's an anterior effusion and a posterior effusion. So you need to be able to see anterior and posterior to get a good view. That matters because sometimes it'll look like there's a effusion up here up front, but there's nothing in the posterior. You can have anterior epicardial fat pads that look like fluid. So if you have fluid though around the heart in the anterior and the posterior, that is pericardial effusion. But yeah, you can see there's the wall of the heart right there with the fluid surrounding it. And then you use your liver as an actual sonographic point. Left upper quadrant is in general the hardest view to get. Your orientation of the probe, the bottom of the probe is laying against the bed, you're aiming up towards the person, your spleen's more recessed than up against your thorax than your liver is. It's harder to get, sometimes you have to go intercostal views. What you're looking for is to get a view of your spleen, your diaphragm, and your kidney. That T point right there is what you want to see every time. And what you'll see is the fluid creep down just like before around here, or alternatively it'll layer back here between the diaphragm and the spleen. And you can see spleen right there, kidney down there, fluid layering out. Fast, last view is your pelvic, and you do 2 views of this. So you get your long pelvic, there's bladder, there's uterus, and then all your stuff down lower. No fluid out there. Here's some trace fluid around it, and then lots of fluid around it. And then you should turn it 90 degrees, an orthogonal view, and get you see what you can find in there. There's some trace fluid in a guy. There's no uterus there. So the best way to learn is actually to do it. So if we can get someone up here to lay on the table, we'll start working the machine and let y'all run through it.